Welcome everyone to this first session of the Cancer Clinical Genetics in Africa discussion session. I'm Tim Rebick, and there are a couple of us on this panel, including Priska Adejumo and from Nigeria, and Achille Manirakiza from Rwanda, and there may be some others who will join. As you know, we are all hoping that each of you will have seen the session lectures. And so for each of these, today, tomorrow, and Thursday, this week and next week, we hope you've seen them already. In the past hour, each of the lectures will be broadcast for you to see, and now we'll have the live discussion. So I hope that if you are there, what we'd like to do is have some questions that you can put into the chat or Q&A, and we will follow them, and I'll have each of our panelists then answer the questions, and we'll have a discussion. Unfortunately, since there are so many people in the course, we can't really have a live discussion with individual members, but hopefully we'll be able to have a discussion that you can use in the chat. So let me just get started. In the previous session, Dr. Huma Rana, who's at the Dana-Farber Cancer Institute, was able to present to us the basic information about cancer clinical genetics, some of the hereditary cancer syndromes, and other activities that are used in cancer clinical genetics. So you should hopefully now have a basis. So please type your questions in about any aspect of the lecture that you heard, or about the questions that have arisen outside of the lecture. Caroline, are you raising your hand? No, sorry. Got it. Great. So we'd like to begin. I will just introduce Achille and Priska. Can you each introduce yourselves? Achille first.
Yes, hi. Happy to be here.
Thanks, Achille. It was very hard to hear you, but thank you. Priska? Oh, maybe Priska is not there. I'm sorry. All right.
Sorry, well, I muted myself. Yes. Oh. No, I'm here.
Oh, okay, great. Please introduce yourself. Still there, Priska? Yeah, we're having a little trouble hearing. Well, let's just keep working on that. Let's keep working on that. I'm sorry, everybody, for that.
Sorry, Tim, you called me.
Yes, I just wanted you to introduce yourself.
Oh, good evening, good morning, good afternoon from wherever you are. So super excited to be here. My name is Priska Olabisi Adejumo, a professor of nursing from the University of Ibadan. Thank you.
And Dr. Akingbade, would you also please introduce yourself, if you're there?
Oluwadamilare, introduce yourself. He's from Hong Kong.
It's okay. He can do that later. So why don't we start answering some questions. Again, please type your questions into the chat. I wanted to give one answer to a question that came up during the lecture that was just played. And that question was, are there African-specific cancer panels that are used? And the answer is currently no, not really. The goal of genetic testing is to have identified cancer genes that are involved in susceptibility. And those cancer susceptibility genes are thought to be the same for everyone. Whether that's true or not, I don't think we know, because there haven't been enough studies in Africa to really address that question. But the goal is to have been able to identify cancer genes that are predisposing to any population. So currently, the cancer predisposition panels at least those that are commonly used clinically, have the same sets of genes, although different companies have different sets. And there haven't been specific panels developed for African populations. Now, having said that, there are companies in Africa who are developing panels for genetic testing. And so those are out there, and they may have slightly different genes, but they're all based on the same kind of selection of what genes are thought to be important. The difference is, of course, sorry, I'm hearing that there's a lot of people can't hear me. I'm not sure how to increase that. I think if you can increase your volume, that might help as well. I'm not sure. So the main thing is that all of these panels use genetic sequencing. And so the sequence analysis allows us to find any mutation that's out there. So there may be different mutations in different populations that arise. They may occur at different frequency, but once you've sequenced a gene, you should be able to have that, that any mutation found in any population. So I'm not sure if that answers the question, but that at least begins to help us understand that we don't expect to find African-specific cancer susceptibility genes. We may expect to see African-specific mutational patterns. Great. So I know, Caroline, you can't, but I don't know how to make you the host. So I'm sorry, I don't know how to do that. If you can tell me how, I'd be glad to.
It's okay, I'm the host now, no worries.
Okay, great, thank you. So there's another question about, and this is from an anonymous attendee. What aspects of the cancer do we need to consider when describing the disease scope? I'm not sure I understand the question entirely. So if you have a little explanation for that, I'm glad to try to answer it a little bit more. I think that maybe your question is, are there patterns of cancer that help us identify hereditary cancer syndromes? And so, for example, we often find that cancers that are diagnosed very early in age tend to be more hereditary. And there are phenotypic patterns, histopathological patterns that are unique, or at least more frequently identified in some of these hereditary cancers. So just to give an example, breast cancer. Breast cancer in the United States occurs in the 50s, 60s, et cetera. In hereditary breast ovarian cancer syndrome, it may be diagnosed closer to the 30s or 40s in age, and it tends to be estrogen receptor, progesterone receptor negative and HER2 positive. So meaning their triple negative cancers are quite common in these hereditary cancers. So there are hallmarks of hereditary cancers that we can identify. As Dr. Rana said in her lecture, Lynch syndrome patients tend to have mismatch repair patterns in their tumors. And so they occur at an earlier age and have a certain molecular phenotype. So if that's the answer to the question, that's certainly there are certainly hallmarks of cancer. Priska, did you want to add anything about the patterns you see in Nigeria? Because you've studied molecular and phenotypic patterns, age at diagnosis of breast and other cancers.
Yes, thank you very much, Tim, for the brilliant answer given already. I want to say in my environment, triple negative breast cancer is very common, and the prognosis is very poor in our environment. And when we see that, one characteristic of it is that it is very aggressive. And so you want to do everything you want to do right on time when you notice it. And that is why the red flag alerts are very important. And then we want to make sure we catch young the family members of these individuals in our clinic in UCH. When we see triple negative, we also become very aggressive in managing this category of family members, especially where we come across a positive family history. Apart from that, for the question you just answered about scope, I was trying to find out what that person really meant by scope, because my mind went to endoscopy and scopes like that. So I wanted to be sure whether scope in terms of how the expansivity or scope is for investigations that are done for patients with cancer is what this individual is interested in finding out. But generally speaking, it's very important in obtaining history from this patient to want to categorize the 3 specific areas of cancers, generally speaking, whether it's breast cancer or any kind of cancer. We want to make sure whether it is cancer from the history we obtain that occurs sporadically, whether it's something that is rare that just happened, or maybe it is familiar or it is hereditary, because that has implication for surveillance, it has implication for recommendations using the NCCN guideline, and it also has implications for management of this category of patients. But generally speaking, in facilities in UCH, we want to make sure that we follow up when we see triple negative, which is very rampant in our environment. Thank you very much.
Thank you, Priska. I'd also like to introduce Annette Uwineza, who's joined us as a panelist. Annette, would you like to say a word or two about yourself and your background?
Oh, thank you, Tim. As I said, I'm Dr. Annette Uwineza. I am a medical doctor with a PhD in human genetics. I am working at the University of Rwanda and the University Teaching Hospital of Kigali. I am really interested in genetics, especially in cancer genetics, and I have a presentation also tomorrow. Thank you very much.
Yeah, great. Please join us tomorrow. Annette and Priska will both be giving the lectures at 1300 GMT. Immediately following that will be the discussion session like we're doing today. So there's another question that's come up.
Please, Tim, do you know what time that be tomorrow?
It's 1300.
Okay, tomorrow. It would be nice to let people time for tomorrow.
Yep, it has been in the emails, but we will certainly we'll send the email out. People who have registered should have that, but we'll make sure that they do. But the lecture tomorrow is at 1300 GMT at the same link that was at the 10 a.m. today, or the meeting we had earlier. And then following that is the discussion session which will be at 1400 GMT using the link you're in right now. So great. So there's a question from Samuel Guai about that says, one way of treating cancer highlighted in the previous session was to complete removal of the affected area. How do you determine where to cut or what proportion to remove so the process is complete? So there are 2 things to think about there, and I'll ask our other panelists to comment in a second. One is about preventive surgery, and one is about treatment. And both are relevant in the context of hereditary cancer settings. So in prevention of hereditary cancers, surgery is often used to remove the tissue before it becomes cancerous. So preventive oophorectomy, preventive mastectomy, preventive colectomy, and others, depending on the syndrome and where the tissue of risk is often used. So for example, if you have an APC mutation, if you have a familial adenomatous polyposis mutation and you have that syndrome, it is not unusual to remove the entire colon prophylactically so that it doesn't become cancerous. In breast and hereditary breast and ovarian cancer with BRCA1 and 2 mutations, you often remove the ovary, both ovaries, at a relatively young age, meaning after childbearing or at age 35 or 40. And that's prevention. Again, there's a lot of preventive strategies. For treatment, and again, I'm glad to hear other people who might be surgeons who treat these kinds of cancers. In general, the surgery for breast, ovary, and colon and other major cancers is used as as treatment would go. And I think normally, but I think the key thing to keep in mind is that when you have someone in front of you with a cancer, and they seem to have a hereditary syndrome or they've tested positive for the mutation, there are 2 things to think about. One is treatment, what you're treating, and whether you also want to undertake prevention strategies at that same time. So for example, you might say this woman we found has a breast cancer and she's BRCA1 positive. We need to treat her breast cancer, and that might involve surgery or radiation, but we also may want to have a surgery to prevent future breast cancers, contralateral cancers. That's a prevention decision. And so the prevention and the treatment decisions need to be thought of simultaneously sometimes, but they aren't the same thing. And that's just one opinion I have about how to think about that. You're not necessarily removing all of the tissue in order to treat the cancer, but you might remove all of the tissue, both breasts, for example, to prevent future cancers. Does anyone, Annette, Achille, Priska, want to comment on that?
Yes, thank you very much, Tim. I was going to say that specifically for colon cancer, the portion that you are going to remove is also very related to the size and at the stage of the tumor.
Yeah.
What stage this person is. You know, you talked a lot about preventing, but where this individual is already with colon cancer, what determine the amount of tissues that are going to be removed is dependent on what stage that colon cancer is already. And what is important, generally, I'm not a surgeon, I'm a nurse, but with my experience of patients with colon cancer, what is important is even when you think you have removed all the areas with cancer, you want to remove some areas that are normal as well, along with the areas that are cancerous, because you don't want the patient to have fast spread as quickly as possible. So you don't just deal with the areas that you can say, okay, this is where cancer is, and leave the other areas. So it's very important to consider the stage of the cancer before you talk about amount of tissue you want to remove. I just wanted to add that to it. Why surgery is oftentimes the main treatment for early stage colon cancers. I understand the aspect of prevention, which is wonderful. And that is where prevention is at its best. The amount of polyps that you want to remove if the patient has APC and the rate at which it is can go a long way in prevention. But where it is already colon cancer, surgery is oftentimes the main treatment for early stage colon cancers. But you want to think about not just the aspect that has cancer when you are removing, but as well as other areas that are normal as well. I just wanted to add that. Thank you. I don't know if there's a surgeon in the house to throw more light into this.
Achille or Annette? Yep, go ahead.
I have a small comment. What I can add to what Priska has said, that even me, I'm not a...
Oh, sorry, Achille, we're having trouble hearing you.
Something? Can you hear me?
Not really. We can hear that you're speaking, but you're not coming clearly.
Actually, do you have two devices open at the same time?
Excuse me?
No, I wanted to find out from Achille if he has two devices, because he's connecting.
I think he just popped out. He may be having trouble with his connection. So he'll come back, I'm sure. Annette, why don't you go ahead and comment?
So my comment was, unfortunately, in our country, most of the patients come with complications, for example, obstruction, bleeding. So what I want to emphasize is to make this, to strengthen the prevention. I think that in Africa, most of the hospitals are having colonoscopy. Why genetics is not yet available, but maybe those colonoscopy, and we need to put emphasis in prevention. It's what I wanted to say.
Thank you. Yeah, and I think that just to be clear, I did my comment earlier was really the same as Priska's, that when a patient has cancer and needs to be treated, there's the treatment and there's prevention of future cancers at that time. They're two different decisions that need to be made. And I think that's what Priska and we have all been saying. And then there's also prevention before people get cancer. So there's a prevention aspect during the time of treatment that one needs to think about. But anyway, good. So George Rebello is asking a question. Are there African-specific sources that can be exploited in order to determine possibly unique or unusual changes that may be African-specific, something like an African mutation database? So there are a couple of such things being developed. As you can imagine, it's quite new and not very extensive. So certainly there are mutational African-specific mutations that have been reported for some hereditary cancer syndromes. And there are also descriptions of mutation testing from individual papers. So Priska's work, for example, has some of those reports. We have a report from the Worldwide SIMBA Consortium that shows the distribution of mutations worldwide and identifies some likely African-specific mutations. And I'm glad to share those papers with people if they'd like to see them. And then there are a couple of countries, 54Gene and H3 Africa and others in Africa have been building mutational databases for their own purposes. But there isn't a centralized source that I'm aware of that specifically identifies African-specific mutations or mutations found in African populations. There are individual ones, but I don't think there's a centralized source necessarily. Anybody want to comment?
I don't have my hands on anyone specifically, but I know Professor Fumi Olopade has a number of articles that pointed to that. And I was going to say in our own study in Nigeria that we did, and the first 100 patients that we had opportunity to subject to genetic testing, we found TP53, we have BRCA1, BRCA2, and one other one, TP53, I'm not sure, I can't remember the fourth one, which were very common among those first set of 100 patients that we saw. It's only 62 that came up with significant results. Quite a number were VUSs, and after that, because we did not have any means of further reclassification and recategorization, we stopped reporting the VUSs. And so most of those variants were among TP53, BRCA1, BRCA2, and the fourth one, which I didn't remember right now. So yes, they are, but I don't lay my hands on those papers now. But I know Dr. Fumi Olopade has quite a number of them. And they have actually worked on a very important breast cancer indicators that can be used for Nigerians, that can be used in the Blacks, not just Caucasians, because somebody was talking about using indicators and indices that are from Caucasians among Blacks. Yes, this is being tested currently. It's been done and it's been proven, and we are testing it in large population among Nigerian participants to see how it goes well. And that's one very important breakthrough for the breast cancer study in Nigeria by Dr. Fumi Olopade and her team in Nigeria. Thank you.
Thank you. Yes, that work has been really seminal in helping us to understand African mutations. And of course, that work has contributed towards some of the large collaborative studies of worldwide mutations in BRCA1 and BRCA2, among others. So that's been, again, for those of you who are interested, I'm glad to put the major papers that Priska and others will have referred to today on our website that you use to register, and we can begin to try to get access for some of those key papers if people are interested in that. So there's a question here from Ramhadani Shambuso. Is it possible to assess the mutational burden in Lynch syndrome pre-somatic mutation carriers using liquid biopsy? So as you may know, liquid biopsy is very new, and liquid biopsies usually use blood that attempts to identify mutations that have been sloughed off of tumors that circulate in the blood. And so right now, there are very few studies that have, platforms that have been very successful. And in fact, there are companies that have used these technologies. There are many papers that have reported on these technologies, and to date, they're still somewhat limited. They're still early in development. And the main issue there is to use this technology to identify cancers early. And that's been the main problem, because some of these cancers can be identified very well once they're advanced in the blood using liquid biopsy, but to identify them very early has been really difficult. And that's true for essentially all cancers at this point. So the same thing for Lynch syndrome, that's really not been something that's been studied, and also for early detection of Lynch syndrome associated cancers has been very difficult to achieve. So that's why germline mutations taken from blood, not somatic changes, not tumor tissue changes from blood, but germline changes in Lynch syndrome have been so important, because if you found to have a Lynch syndrome mutation, you can then direct screening for these individuals or early treatment if needed, and that sort of thing. So that's really where this comes in. Not so much liquid biopsy, but screening for genetic mutations in the germline, and then following up on those mutations with screening activities. Does anybody want to further say anything, Annette or Priska, about that liquid biopsy?
No.
Yeah, Annette, yeah, it's very new, yeah. Good, so second question is, what is the correlation between mutation burden and colorectal cancer disease initiation or progression in pre-symptomatic Lynch syndrome mutation carriers? And that's what I was kind of just trying to describe, is that we really don't have a good sense of that. What we do know, or what we believe from the limited data that there are already, is that we have a lot of sorry, I was going to say, somebody can mute. It's been hard to.
Cranky. Your voice is breaking. And
sorry, I'm here now, and Ashil is back. I don't know, Ashil, if you're, yeah, someone is.
Yeah, so I was going to say most of the studies here are quite difficult to conduct, in the sense that we have a very diverse population in Africa. Mostly the eastern and southern part of Africa have different morphologies and phenotype than the people in the western side of Africa, and also the northern side. So you'd find a lot of heterogeneity in terms of the findings that you'll have. But there was a small study that was done on a limited population in Rwanda, for example, that was published this year, and they found about the same mutational burden in breast cancer in BRCA1 and 2. It was similar to the Caucasian. So it could be interesting to have a larger part, a larger sample size of the population tested for this. I was also going to touch a little bit on the prophylactic surgery question that was asked before. There is a paper that I have in front of me that was published sometime in 2017. It asked prophylactic surgery for whom, when, and how. It essentially speaks of if you have an early disease, the earlier you have, the better prognosis you have, and also the larger surgery you'll need to be sure that you removed all the possibility of the disease to come back. So it's a tricky situation, at least on our side, because in my 3 years of practice, I've seen a 20-year-old with breast cancer. I have at least a good cohort of 10 patients between 20 and 30. This is something that is untold of in many parts of the world. And I have multiple others between 30 and 40, and these are good, a good population to already have a sample from and test for, whatever hereditary carriage that you might be having. So the early disease you have, the better you have in terms of prognosis, and also surgery is good to be carried. At least what is known so far is in breast, ovarian, and colon, just to emphasize on what my colleagues have been saying. But the earlier, the better, really, as it has been emphasized before. Thank you.
Thank you. And I think that's a really important point for everyone to be thinking about, is that the reason that genetic information has value, the reason that we do genetic testing, is because we can act on that information. If you do genetic testing and there's nothing you can do, there's no preventive surgery, there's no ability to catch the disease early, there's no screening, then genetic testing is of limited value. But in fact, most of the genetic tests that we're talking about, the genetic syndromes, when you're tested for a gene and you're positive, you actually can do something about it. And you can detect the cancer early and you can prevent mortality. And so that's really a key principle of this field, is testing is of value when the results are actionable. And so we need to keep in mind there's a lot of genetic testing out there that doesn't really confer much actionability, doesn't allow you to do much to prevent cancer or find it early. And so those are very important key things to remember as you're thinking about the value of testing. There's a question here from Gabi Macabela asking about the polymorphisms in genes in pro-inflammatory markers that might predispose to cancers, and particularly hepatocellular carcinoma in Africans. So, you know, hepatocellular carcinoma is an important disease. It's very heterogeneous in its etiology. In the United States, hepatitis C virus is really important, as well as cirrhosis, alcoholic cirrhosis, and fatty liver due to obesity and things like that. In Asia and parts of Africa, it's more hepatitis B, and in Africa, hepatitis B with aflatoxin. And so, as you know, there are a lot of different causes of hepatocellular carcinoma that varies. And so there haven't been a lot of genome searches for hepatocellular carcinoma, and you really need to account for the very important influence of other infections and other exposures. So there is some information about pro-inflammatory markers, but the problem is they're not really clinically actionable at this point. There's some basic biology that says, yes, inflammation is important, but it's not clear entirely that you can do anything clinically with those data yet. Anybody else want to comment on hepatocellular carcinoma or inflammatory markers?
I believe the answer you just gave responds to another question by, is it Kigile Bati?
Yes.
Who said, yeah, I lost my mom last year of HCC, no history of hepatitis, non-alcohol drinker. Should we, as the children and family, consider genetic testing and counseling to check if we are at risk of developing the same? Yeah, it responds to it. Yeah, pretty much.
Yeah, and the problem is we unfortunately don't have very much to offer in terms of hepatocellular carcinoma for families, and that's a problem. Yeah.
In most of the families that I've followed with a history of HCC, there is usually a history of hepatitis that would come from a single transmitter, perhaps a parent or a sharp or anything that could have caused hepatitis B or C. So there is really nothing that suggests that there could be a genetic mutation around that, but it's usually the same etiologies as Prof. Tim has mentioned.
And I think that there's some real great examples. China, for example, has had near universal hepatitis B vaccination. And as a result of that, there's been a very big drop in liver cancer. But also they've limited aflatoxin exposures and things like that. So it's really, for liver cancer, at least, more of a primary prevention strategy than it is a genetics strategy for avoiding disease. And I know that that is a difficult thing when you have a family history and you'd like to be able to act on what looks like a hereditary pattern, but in fact, a lot of it really seems like it's environmental as opposed to genetic. And I understand the person who wrote the question says that their relative did not have the traditional risk factors. So then it becomes very difficult. Anyway. Here, David Swanepoel asks, are there examples where somatic mutations have only occurred in the progenitor germline cells of a mother or a father? And would it not seem to be seen in germline testing of the two parents or other family members? How would this affect the interpretation of the case and any possible targeted treatment options? So yes, there are de novo mutations that have been identified. I don't know that we can say how common they are as opposed to germline inherited mutations, but there's no question that de novo mutations in the germline can arise, which give the same symptoms, the same risks. as an inherited mutation. So that usually is found if they're able to say, well, the individual in question, usually because they're diagnosed with a cancer, has a germline mutation, but their parent doesn't. And but so we don't know. But I think in general, we would argue that if it is a germline mutation, that the symptoms, the risks are similar. And I don't know that we have great information to say that that's true always, but I think that's what people often assume when they're doing genetic testing and then management of risk. And so I'd love to hear what others think about that, but there isn't a huge amount of information that would imply to us that a germline de novo mutation versus a germline inherited mutation would be managed fundamentally differently. Any thoughts about that from anyone?
I think that's, in fact, you picked the word de novo from my mouth, because that's exactly what I was thinking about. The only thing that could be responsible for this kind of scenario is de novo. So that's just the only thing that I want to think about. And you have rightly put it that how true this is, no one knows, because these days, never say never. New things keep cropping up, and a lot of things can change. But the thing is that it is new and radically just comes up like that. So it's possible. And the answer from me is de novo. Thank you.
Yeah, and I think that, for some of these mutations, there's so much variability in penetrance, meaning if you have one of these mutations, no matter why you have it, inherited or de novo, there is a lot of variability in the risk that you'll develop cancer, in many cases, which site, like a P53 mutation or a BRCA2 mutation, you are at risk for cancer of multiple different sites at different ages. So even with any kind of germline mutation, there's such variation. It's not entirely clear that whether it's de novo versus inherited, that it makes as much difference as the natural variation in cancer risk that we see overall. So it's a good question. It's one that's, I think, fairly hard to answer without more research. So another person asked, do cancer hereditary mutations confer a specific type of disease in a particular population? For example, does the type of BRCA1/2 mutation most common among Blacks or Africans confer a specific type of breast cancer? So that's a great question, and one that I think that we need to also spend a lot of time researching, and we don't have enough data to really answer that well. What people will generally say in the absence of good data is that there are differences in the distribution of mutations across different populations. And we know, at least in the BRCA1 and 2 setting, that there are mutation-specific risks, meaning, for example, we've identified in and others have identified in BRCA1 and 2 breast cancer cluster regions and ovarian cancer cluster regions and prostate cancer cluster regions, meaning if you have a mutation in one of these regions of these genes, you're more likely to have a breast or more likely to have an ovarian cancer, for example. And we also see that there's some variation in where those mutations occur in different ethnicities. So again, that's a sort of a long, complicated answer to your question, that there are some genotype-phenotype correlation. There is some risk distributions that vary by where your mutation lies. And so there may be such differences in the pattern of cancer that's diagnosed, either the type, the histopathology of the cancer, the aggressiveness of the tumor, or the age of diagnosis. But we really don't have a lot of data that makes that clinically actionable again, where we would say you are African, or so let's say you are Nigerian, you have this mutation, and therefore we expect you will have a more aggressive cancer. Sometimes you can make that kind of inference, but it's not clinically very clear. And I don't know that anybody changes their clinical practice based on that information. Anybody of the panelists want to comment on that?
Thanks, Tim. I'd only add that different populations in Africa would have different deletions on the BRCA1 and 2 genes. For example, deletions that you'll find in the Northern African population is different from the Western African population, also Southern African. But the implications on the treatment really do not change. And it doesn't really also influence the type of breast cancer you'll get. The histologies tend to be the same. We still have a lot more, in general, histologically, we still tend to have a lot more ER/PR positive disease, luminal A and B, and a little bit more of triple negative breast cancer, which is a little bit on the rise now, but that won't change the treatment whatsoever. Perhaps in advanced diseases presentations, maybe then we could add something related regarding that, but it won't, whether you have a different histology from whatever other part of the world will not change the treatment, really.
Yeah, and that comment, Ashil's comment really relates to the next question as well, that many of the treatments that are used in Africa have been developed in high-income countries and based on experience in European populations, European descent populations, and their genetic makeup. And a lot of the primary work that was developed in treatment, in therapeutics, are really not done in African populations. And the question is really, does the underlying genetic makeup of the disease in African populations change how you might think about treatment regimens? And that's really very much, I think, related to what Ashil just said, is that we don't really do anything to change the treatment regimens, primarily because there's no evidence, there's no data that suggests that some individuals will respond differently depending on where they live, where they come from. There certainly, when people make clinical treatment decisions, they evaluate toxicities, they evaluate response, and may change their treatment plan based on that. But it isn't necessarily something that's been done on the basis of race or country of origin. I don't know if anyone would like to comment further on that. I see Dio.
Yes,
oh, sorry.
Okay.
Go ahead. Yes.
No, I was just going to say that it's a common fact that cancer is a common disease. And so it's no surprise that many families that have at least a few members who have had cancer at one point or the other. And sometimes certain types of cancer seem to run in some families. And in some cases, that might be because the family members share certain behaviors or exposures or characteristics that increases cancer risk. For example, if you take smoking, cancer risk might be affected by other factors that run in a family. Take, for example, obesity, and that tends to run in some families and tend to have some genetic implications. But in some cases, the cancer is caused by an abnormal gene that is being passed along from generation to generation. And so even though you refer to that as inherited cancer, let's take note that what is often referred to as inherited cancer is not an abnormal gene that is inherited. It is the risk to that cancer that increases as a result of that generational susceptibility. So the point I'm trying to make is that in our environment in Africa, like in Nigeria, there is no clinical trials going on. So if you don't have clinical trials going on about specificities into specific kind of drugs, the option that is left is to make use of what is available. Are we going to say, okay, because this is coming from this environment, so the patients who are living with these kind of conditions will not be exposed to drugs that we know is working and is going to be useful for this kind of patients. So we do not have clinical trials going on. We do not have funds for research as it should be that could help us to do specifically tailored, general, large-scale population studies with which we can come up with findings that we assist us to do this. In the whole of Nigeria, we have only one clinical trial going on currently. I think that's the first of its kind. And so what I'm just trying to say that, yeah, I quite agree with all the points we have made, but let's also remember that we do not have some things that could position us to large-scale studies, that will be population-based studies, to clinical trials that will make us to come up with findings that will be specific for our own environment. But like we have rightly explained, if the treatment is not based on race, is not based on those things that we're looking at, then nothing spoils. Thank you.
Thank you, Priska. Yeah, very good points, very important points. And I think many of the questions that come up in this session, as well as in general, is, we need more research, we need more data in order to answer the questions that are being raised. And Priska stated very nicely what the kinds of things we need. I'd like to just introduce Dayo Fadalou, who just joined us as on the panel. Dayo, if you're there, the question that was just asked is about treatment regimens and the fact that they were developed in non-African populations. Is there anything to think about when they're translated or transported to African populations? Any comments you'd like to make on that?
Thank you, Tim, for the introduction. I wanted to sort of make a contrast to some of the prior conversation and discussion about different types of or different biology of breast cancer based on the genetic predisposition. And I wanted to contrast that with Lynch syndrome and colorectal cancer, because the biology of the type of colorectal cancer patients develop is actually different in Lynch syndrome versus the routine colorectal cancer. And there are also some treatment implications with regards to likelihood of response to chemotherapy or likelihood of responses to immunotherapy, depending on whether or not there are deficiencies in the mismatch repair genes. So just to say, it is, some of this stuff can be disease specific and can be dependent on exactly what kind of genetic predisposition we're talking about.
Great, thank you. Let me move. There's another question from Henrietta Monnier about retinoblastoma. She asks, are bilateral retinoblastoma cases invariably hereditary, or are there instances where bilateral retinoblastoma may be sporadic? And so the bilateral retinoblastomas are usually very early onset and are hereditary in the sense that the individual, the patient, has inherited a germline RB mutation, RB1 mutation, and the second mutation arises somatically in the retinoblasts, and so these are usually thought of as hereditary in that sense. But really, a retinoblastoma is caused by two mutations in that same gene, and you can get two mutations in a sporadic in an individual that doesn't have those germline mutations to begin with. So it is possible, and I'm not an RB expert, maybe some of the others can really talk about this, but it is possible that some of these are bilateral cases are in fact not caused by a first hit in the germline. But you would expect, first of all, that they would be occurring later, much later, and that they would be extremely rare because you'd have to have two mutations in the same gene that knock out the tumor suppressor function, and that has to happen in both eyes. And so it's said to be, very, very, it's got to be very rare. And with respect to the autosomal dominant, so the pattern that we're talking about here is something that is something that's, it's incredibly rare, first of all, to have these RB1 mutations in the first hit. So it's very possible that you'll have a child that has had inherited the first hit through, first of all, a somatic change from one parent, a de novo mutation, or it could be something where the penetrance of that mutation is lower, so the parent didn't develop it. And it's hard to say, but and so that's there are a lot of different scenarios. But if you think about this as under the two-hit hypothesis, where you just need those two hits, and how you get them determines how quickly and how severely the disease, the cancer, will arise. That's that's one way to think about this problem. And I would also say, it says it's autosomal dominant, but autosomal dominant is really thought of in two ways. It's really, when you typically think of autosomal dominant, you think about what the pedigree looks like. And so that's a different concept than what the underlying molecular etiology is. So autosomal dominant tends to be in every generation, penetrance isn't always 100%, but many of these very rare mutations don't appear in an autosomal dominant fashion in the family because they're de novo mutations, because their penetrance is lower, things like that. And so distinguishing the molecular etiology of a germline hit with a second somatic hit that might produce an autosomal dominant familial pattern, they're two kind of different things to keep in mind. Would anybody else like to answer that?
Well, I don't see much of this, but the few cases that I have seen, one observation I have made is that the unilateral retinoblastoma is usually sporadic, while the bilateral multifocal cases are often familiar. The question this person is asking is, can it be sporadic? And I have seen both, but my observation, generally speaking, is when it is unilateral, then most often is sporadic. But when it is bilateral multifocal, then it's familiar. So you can see that the parents have that, unlike when it is unilateral, and it can then become sporadic based on clinical observation. Thank you.
Any other?
I have a small comment also. What we can add when it's hereditary, the occurrence of the cancer come early in the life, less than 2 years, and when it's sporadic, it can come at older age, more than 2 years. Okay.
That's right. Yeah, that's exactly the model that you would expect under the two-hit hypothesis of requiring both copies of the RB1 gene knocked out. So that's exactly what you'd expect to see. And there are a number of comments here. I'm not trying to avoid them, but a number of comments that really are acknowledging what we've been saying about the need for more data in Africa on genomics and genetics, that collaborative work and additional funding is required. And I think that that's something that this group, the group who is organizing this training and the group who is trying to get people together to have this conversation, really want to promote studies in Africa, help people get funding. And I just acknowledge, Dr. Adejumo and Fumi Olopati and the group at University College Hospital in Ibadan have done that really well by creating this kind of basic science that is required to answer many of the questions that are coming up today. And so reading their papers, I think, would be really a good start, because they've set the stage for this. And I also want to mention Dr. Uwaneza and Dr. Manarakiza, who are on our panel today in Kigali, are part of a pilot study right now to develop genetic testing, genetic counseling, and the clinical management of these high-risk patients. And that's being done also through an NIH grant. And so there are examples of people doing this work. And so I just want to make sure that people are aware there are opportunities and should be many more. So there's another question here about socio-demographic factors that affect acceptance of treatment plans by patients in African populations, given diverse cultural practices. So I'd like to ask anybody on the panel who has experience about treatment and how people think about it in Africa, and particularly if we can relate it to hereditary cancer, if there's any way to do that. And I know a number of you on the panel have had that experience. So would anybody like to comment?
From my end, I think the platform is changing. Some years back, when cancer used to be a disease of middle-aged and elderly people, the context and the discussion is different. But now that you have young people, coming up with cancers of different kinds, then the socio-demographic factors like age is playing out in a different way, unlike how it was before. That is one. Two, there used to be a popular misconception that cancer is not an African disease, it's a white man disease. But we all know the reality today. Okay, that's part of my slides of presentation tomorrow. But the point, it is true that it is not an issue of race. And so when you're looking at social demographic factors, when you talk about age, gender, maybe to some extent. I mean, there are factors that, like obesity, women generally speaking tend to gather weight after middle age, unlike men. I don't know, like men, but generally speaking, that belongs. So if you're looking at it, these etiological factors in terms of social demography, then you may want to be looking at the issues of age, you want to look at gender, and you want to look at how does that modulate acceptance of treatment. Treatment plan, and I have patients who come to clinic now and are accompanied by their husband. That's not there before in Africa. The mere diagnosis of cancer makes a family to pack out of his house and leave his wife alone. I know a lot is still going on, but I'm just saying that the terrain is gradually changing. It's not exactly how it was some years back that it is presently. And I wanted to contribute to the last question that you talked about funding. I think where we really need help is in the kind of PhDs that we are having. Many countries of the world invest a lot on their PhDs, so that by the time you're coming out, you are coming up with your PhD, you are almost an independent investigator. But we know that many supervisors, many mentors do not have laboratories of their own. Many supervisors, many mentors do not have research of their own. They do not have research grants of their own. And so it's difficult to absorb the students, the PhD candidates into an already existing grants or already existing projects with which they can go ahead and carry out whatever projects they want to carry out. So I'm reflecting back on that funding. Thank God for the explanation that you gave concerning Dr. Olopade, myself, and a few others. That's fantastic, and that's wonderful. But how many of such do we really have on the planet of Africa? We need proliferation of that. We need a lot of that, especially if you are investing in a PhD candidate, you are investing in a nation, you are investing in a generation. And the multiplier effect of that is whether it's in medicine, is in nursing, is in physiotherapy, is in pharmacy, whatever profession, among all the health professions. If this is an area that is going to be focused on to ensure that the caliber of PhD that are going to be produced are going to be PhDs that really work what we're talking about in terms of independent fund to be able to carry out good time studies that will match with what we have in other parts of the world. I think for me, that will go a long way to help produce data that will really be scientific, that will be critical and empirical, that we can, that can influence practice, quickly than we are experiencing presently. So two things: one, the platform based on social demographic characteristics is changing, and two, funding for me is needed to be pumped in PhD programs so that the caliber of PhDs to be producing can have a multiplier effect quickly on the soil and the continent of Africa. Thank you.
Thank you very much. We're really just out of time. If any of the rest of you have any comments that you'd like to end with, Annette, anything final words to say? If not, that's okay.
Nothing from us.
What I can add is that as we continue to say, to emphasize in doing research in Africa, because the African population is very diverse, it's a field which is still vital. So, and if we want also to contribute to the care of Africa in our continent, we need also to conduct also those genomic studies, because even though here we are on the sides of prevention, also there is also the side of treatment, where we need to see if African patients really respond to the treatment which are on the market, because most of them are usually manufactured and experimented on people from other populations. So we need to do more research in our country, in our continent. Thank you.
Thank you. Achille or Dayo, any last words?
I don't have much else to add, but I agree with the comments Annette and Priska have made, and the importance of doing things locally and engagement locally.
Thank you. Achille?
Nothing from my side, really. Thank you.
Great. Thank you, everybody. So time is up, but tomorrow at the same times at 1500 GMT, we will play the videos for tomorrow's lectures, which will include Dr. Uwaneza and Dr. Adejumos, who were on the panel today. And then at 1400 GMT tomorrow, we'll have a panel like this with your questions. So if you have, I guess all of you have the links, but if you don't have any, it's the same links for tomorrow. So we look forward to seeing you then, and thank you for participating. Thanks to our panel.
Thank you. Bye-bye.
Bye-bye.